Welcome to video 1 of 6 in our Vestibular Physician series for Australian dizziness clinics. Today we're diving straight into a foundational explanator of vestibular schwannoma, building our understanding right from the molecular level up. We're going to establish exactly why these tumors behave so incredibly differently from other masses in this region.
So, let's start with a macro clinical reality, one that literally drives every single management decision we make for these complex patients. Think about it. Why do some of these tumors just sleep for a lifetime, while others hit the gas pedal and require urgent intervention? Well, understanding the molecular drivers behind that very question is the absolute foundation of our entire clinical approach.
The biological heterogeneity here is honestly profound. Look at the data. Fully half of these tumors show zero growth on surveillance, none. Around 30% are what we call slow growers, creeping along at merely 1 to 2 millimeters a year. But then you have this critical 20% that exhibit accelerated, rapid growth. And this massive variance is exactly why an individualized management paradigm, carefully weighing observation against intervention, is absolutely essential.
Okay, here's our syllabus for today's explainer. We'll cover the clinical anomaly, epidemiology and etiology, molecular biology and genetics, and wrap up with pathophysiology and growth patterns. So a true micro to macro cascade to understand exactly how this tumor behaves.
All right, jumping right into section 1, the clinical anomaly. This is the most common CPA tumor.
When we look inside the internal auditory canal and expanding out into the cerebellopontine angle, we find these benign WHO grade 1 neoplasms. They actually originate right at the glial-Schwann junction. You probably know it as the Obersteiner-Redlich zone. Most commonly springing from the superior division of the vestibular nerve, these masses account for an astounding 80 to 90% of all CPA masses. That's a huge slice of the pie.
But before we go any deeper, let's touch on a crucial clinical pearl. The historical term acoustic neuroma is, well, completely inaccurate. As you can guess from their cellular origin, these tumors arise from vestibular Schwann cells, not cochlear neurons. And that is exactly why vestibular schwannoma is the contemporary standard terminology we use today.
Moving right along to section 2, epidemiology and etiology. Let's look at incidence and origins. So, the established annual incidence sits at about 1 to 2 per 100,000 in the general population. Median age of diagnosis, usually right around 50 to 55 years, with a slight female predominance. However, and this is key, the true prevalence is likely way higher today. Because we rely so heavily on high-resolution MRI for other neurological workups, we're incidentally catching a lot more of these asymptomatic, non-growing tumors than we ever used to. Now, the crucial point here is distinguishing between two very distinct clinical presentations. Sporadic, unilateral cases make up 95% of all patients. And get this, aside from prior low-dose radiation, which is literally the only confirmed modifiable risk factor, there's no established environmental cause. So much for those older mobile phone radiation theories, right? The remaining 5% are tied to neurofibromatosis type 2, which is an autosomal dominant syndrome carrying a massive risk of bilateral deafness and, frankly, behaves far more aggressively.
All right, let's zoom in even closer. Section 3, Molecular Biology and Genetics. This is the cellular cascade.
Whether you're dealing with a germline mutation plus a loss of heterozygosity in NF2 patients or a 2-hit somatic mutation in sporadic cases, the final common pathway is identical. A mutation on the NF2 gene on chromosome 22q12 leads to the biallelic loss of the merlin protein. And without merlin, the molecular brakes completely fail. The RAC1, RAS, and mTOR signaling pathways are unleashed, triggering rapid, uncontrolled Schwann-cell proliferation. It's basically an unstoppable chain reaction. Just to emphasize, merlin, also known as schwannomine, is a critical tumor suppressor that regulates contact-dependent inhibition. So lower merlin expression directly correlates with much more aggressive tumor growth. What's actually really fascinating is that merlin isoforms IN2 differ in their growth behavior, acting as emerging prognostic markers for us. And because this loss activates the mTOR pathway, it makes that specific pathway a highly attractive target for emerging systemic therapies like everolimus, especially for those complex bilateral NF2 cases.
Okay, let's zoom back out for section 4, pathophysiology and growth patterns. We're looking at the micro to macro clinical impact.
So how does this expanding mass actually cause progressive vestibular and cochlear deafferation? Well, it happens through two main mechanisms. First, mechanically. It causes compressive ischemia of the anterior inferior cerebellar artery, the AICA, and the internal auditory artery, literally starving the cochlea of blood. Second, chemically. The tumor chronically secretes neurotoxic factors, things like glutamate and S100 protein, which directly damage the surrounding spiral ganglion neurons and delicate hair cells. And this compressive ischemia can be incredibly drastic and immediate. In fact, up to 10% of patients present with sudden onset sensorineural hearing loss over just a 72-hour window. Guys, this is a massive clinical trap. It perfectly mimics idiopathic sudden hearing loss, which just highlights the absolute necessity of rigorous, gadolinium-enhanced MRI evaluation to ensure we don't accidentally miss a retrocochlear lesion.
If we look at Harvey Cushing's historical 1936 illustrations, they perfectly capture the gross anatomical impact here. You can clearly see how larger tumors aggressively displace the facial nerve and actually physically compress the brainstem. It's pretty amazing how this bridges our anatomical understanding from almost a century ago directly with the highly detailed modern pathophysiology we rely on today.
Now, interestingly enough, despite this severe local damage and massive unilateral canal paresis, you might be asking yourself, why aren't these patients just constantly vertiginous? Well, central vestibular compensation partially corrects that unilateral peripheral deficit through some pretty remarkable cerebellar-mediated plasticity. The brain essentially rewires to adapt, and that heavily masks the true clinical severity of the patient's peripheral vestibular symptoms.
As we wrap up this explainer, I want you to keep these core clinical principles front and center. Vestibular schwannoma is universally driven by NF2 gene and merlin loss. Growth is highly variable. Remember, roughly half of all cases may never actually require intervention. Compressive cochlear ischemia is what drives that asymmetric sensory neural hearing loss pattern. And finally, those NF2-associated cases consistently behave far more aggressively.
This foundational biology leads us directly into Video 2, Clinical Presentation and Diagnostic Investigations, where we're going to unpack the asymmetric audiovestibular syndrome, the gold standard MRI criteria, and the complete vestibular function battery. Which leaves us with a pretty critical clinical puzzle. Considering the silent, heavily compensated nature of this tumor's early growth, what exactly will the diagnostic timeline look like once that cerebellar compensation is finally overwhelmed? Thank you so much for watching this series. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to access all our clinician materials, please visit AustralianDizzinessClinics.com. Please subscribe and rate this series.